Videolaryngoscopy, troubleshooting with D-blade or hyperangulated blade for orotracheal intubation. When you insert the blade inside the mouth, many times you get tongue which is rolled over the scope. You get a tongue on the screen because your scope tip is over the tongue. Why it is so and how to overcome this problem? See, when you are inserting the D-blade or hyperangulated blade perpendicular to face plane, the tongue is going to obstruct the path of your videolaryngoscope. Same way, when you are inserting the D-blade like a direct laryngoscope, also tongue is going to obstruct the path of your videolaryngoscope with D-blade. So in such case, what to do? You have to withdraw the scope and you have to insert the scope parallel to hard palate and soft palate behind the tongue like this. And when you are inserting the videolaryngoscope D-blade parallel to hard palate and soft palate, then you have to follow the oropharyngeal curve, follow the curve of the tongue, follow the primary curve. So you have to make a rotation in such a way that it should follow the primary curve. Look at this. I'm using the D-blade. It has to be inserted in the midline, parallel to hard palate and soft palate, and then you have to rotate as per the oropharyngeal curve. So the tongue is going to rest on this blade, which significantly decreases the force of laryngoscopy. This is another video where I am inserting the blade parallel to hard palate and soft palate, then rotating as per the oropharyngeal curve. So now what happens when you are passing the scope parallel to hard palate and soft palate, go up to the mid oropharynx. As you are reaching the mid oropharynx, you are going to get the visualization of uvula. Then follow the path of this oropharyngeal laryngeal curve. Look, I am inserting the blade parallel to hard palate and soft palate behind the tongue. I am getting the visualization of uvula here. This is the uvula. Then rotating as per the oropharyngeal curve. And keep in mind that sniffing position is an independent predictor for difficult video laryngoscopy. So when you are using sniffing position for oxygenation, change it to neutral or RAM position with video laryngoscopy. So for oxygenation, sniffing position is fine, but hyperangulated blade video laryngoscopy, you have to change to neutral or extension. Why it is so? Because many times sniffing position increases the difficulty level by handle touching the chest wall, not able to insert. But if you make it a neutral or extension, you can easily insert the blade inside. Many times you are getting in this type of view where you are much away from the larynx. Why it is so? Because you have not inserted the blade at the proper depth. See, in such case, advance the blade to a proper depth to get the proper laryngeal view. Many times, for suppose this blue is the larynx. So many times your scope tip is too near to the larynx. What happens? You get this view. You get very good pogo scoring, but you won't get space to manipulate the styleted tube inside. So in such case, withdraw the blade tip little bit, make the room, then you will be able to negotiate the styleted tube inside the larynx. So what should be the optimal view for videolaryngoscopy intubation? This is the optimal view. You will get the complete laryngeal view along with the adjacent structure. Here you are getting the space to manipulate the tube inside. And any D-blade or hyperangulated videolaryngoscopy, preshaping of the endotracheal tube with the stylet is mandatory requirement. So, and you have to bend the styleted tube from the proximal end of the cup, and you should bend 60 to 80 degrees to make it J-shape. And when you are inserting the styleted tube in the midline, don't insert in the midline because you won't get the space to go in. So pre-shaped endotracheal tube during the hyperangulated videolaryngoscopy has to be inserted from the angle of mouth and it has to be rotated towards the larynx. So the tip of the tube is going to align with the laryngeal inlet. I am showing it again. It has to be inserted from the side of the mouth and then it has to be rotated towards the larynx. Now you reach up to the larynx. Now you have to advance the tube inside by withdrawing the tube, withdrawing the stylet. Do not withdraw the stylet vertically up because it's creating a lot of resistance and you get the troubles. What happens? Look, if you are removing the stylet vertically up, tube is going to go anteriorly. Look, anteriorly. It increases the chances of trauma and laryngeal impingement. So you have to remove the stylet towards caudal and towards the ligand caudally. Look at this. Stylet should be removed caudally towards the ligand of the patient. So next session will be on the which videolaryngoscope blade and adjuvants for which patient. Macintosh versus hyperangulated versus channel.